And I thanks to Dr. Arvind Kankane and the UK Neurosciences Society for giving this opportunity in this virtual meeting. And today's topic is the challenges in the Parkinson's disease. And we have a very renowned speaker, Dr. Vivek Kumar, and he is the senior director at the Max Super Specialty Hospital, Patparganj, Delhi. And he has special interest in the stroke, headache, epilepsy, and he has more than 10 publications in the reputed national and international journals. And I came to know just searching on the internet that he has done his MBBS from the Jhansi, the Maharani Lakshmibai Medical College, MD from the GSDM Medical College, and he is also alumni of the SGPGI, from where I did also my DM Neurology. So thank you, sir, and welcome to this virtual CME. And now I hand over the proceeding to the Dr. Vivek Kumar to present his talk.
Thanks, Professor Moria. Thanks for that kind introduction. It's good to know that you have also passed out from SGPGI. So we'll meet sometime. Uh, uh, Thanks also to Dr. Arvind for making me participate in this CME. It's a interesting topic. Parkinson's disease is obviously of interest to most of us, and it is usually said that you can easily pick up patients of Parkinson's disease once you start observing as the patient approaches to you in or walks into your clinic. But sometimes in our busy OPD clinic practice, we tend to overdiagnose or misdiagnose Parkinson's disease, especially when we are dealing with tremor predominant presentation, or maybe when we don't take a proper drug history. So then treating Parkinson's disease again, even a more challenge, despite the fact that we have so many options available. There is a lot of heterogeneity involved in the clinical course of Parkinson patient, and so every patient is a challenge and teaches us or gives us a new learning experience. So I quickly will go through the challenges that we use to face as a neurologist. Let me see if I can share my the slides.
कॉन्फ्रेंस सब ओपीडी वगैरह 8 बजे तक ओपीडी नहीं चलाएंगे. एक पेशेंट था, देखिए ओपीडी.
स्क्रीन शेयर आई गेस.
हाँ, उसी को कर रहा हूँ मैं.
नीचे ऑप्शन शेयर, then you choose between screen share and whatever is open.
This green lower screen share, first you have to open in the background, then screen share, then you can share.
That is what I am doing.
Dr. Vivek, is it a PPT or is it?
It is a PPT. Are my slides visible or not?
No, no. It has not been shared till now.
Yeah.
So you wanted to share the screen or you wanted to share the PPT?
PPT.
PPT.
Mohit, technical team, can you help Dr. Vivek sir?
Yes, sir.
Can you help Dr. Vivek sir to share his this screen or this PPT?
Yes, sir.
Can you help him?
Yes, sir.
Are my slides visible or not?
No, not now.
Mohit, call Dr. Vivek on WhatsApp video call.
Okay, sir.
Let him show you the screen.
Mohit, I'm sending your number.
Sorry.
Mohit, I've shared your number. Just call Dr. Vivek and help.
Dr. Vivek, have you opened the PPT once? Minimized Zoom and open
It has
PPT.
been minimized and now reopened.
Okay. So PPT is open. First slide is open in PPT.
Yes.
Okay, then you go to share. And then you have, you don't see your PPT. First slide.
मुझे लगता है सेटिंग में प्रॉब्लम है.
So what do you see when you click share?
I am seeing blank.
Seeing blank.
Right now, my screen is showing my PPT, but I am not able to share it.
No, when you when you press share, the green one, what do you see
It's
on the
going
screen?
blank.
It's going blank. Okay.
Now I think it
Nothing
is
at all.
coming.
Yes.
Yes.
Perfect.
Yes,
Finally,
perfect. Yes, sir.
is it okay now?
Yes.
So welcome again. Good evening. It is estimated that more than 1% of the population over the age of 60 are affected with Parkinson's disease, and the incidence and prevalence increases with age. The clinico-pathological studies have shown that up to 1/4 of patients diagnosed as Parkinson's disease during life have an alternative diagnosis at postmortem. Sorry. And this misdiagnosis is even higher when only the initial diagnosis is considered, since the diagnostic accuracy improves by time during follow-up visits. So we should continue to revisit our diagnosis if we have problems with the response to levodopa or anti-Parkinsonian treatment. Now, coming to diagnostic dilemmas, the most important differential being when the patient presents with a tremor predominant Parkinson's disease and when you need to differentiate between Parkinsonian tremor from the essential tremor. The second is, of course, the drug history. You should take if there is a symmetrical onset of bradykinesia and symmetrical symptoms or motor symptoms suggestive of Parkinsonism, because Parkinson disease itself starts from the has a asymmetrical onset. So if you are getting a temporal relationship, you should take a proper history of drug intake, the common anti-Parkinson, antipsychotic medications which can cause Parkinsonism. NPH is again a mimicker of Parkinson's disease, so we need to rule out the NPH. And then there are so many Parkinson plus syndromes. Now, typically, as the patient walks into your clinic, you can see the masked facial expression, stoop posture, forward tilt of the trunk, flexion of the elbow and wrist, reduced arm swing, usually one side more than the other. There is slight flexion at the hip and knee, and there will be resting tremor, which increases on walking. And there's a short shuffling gait. So these are the typical findings that you find in a patient of Parkinson's disease. Then we usually follow the UK Parkinson's Disease Society brain criteria for the diagnosis of Parkinson's disease, which is a 3-step process. The first is that you diagnose that it is a Parkinsonian syndrome on the basis of presence of bradykinesia and at least one of the following, like muscular rigidity, resting tremor, and postural instability. That postural instability, of course, comes a little later. The second step is that you exclude the other possible reasons, like when the history of repeated strokes with stepwise progression favoring vascular Parkinsonism, or there is a history of repeated head injury, or drug intake. Drug history is very important. Then a definite encephalitic illness preceding the development of Parkinsonian syndrome, like we see in Japanese encephalitis. Then if you have a more than one affected relative pointing towards the familial origin, or there is a sustained remission, or there is a negative response to large doses of levodopa, unless there is a malabsorption. Strictly unilateral features after 3 years, again, one should look for other possibilities. Other neurological features, the red flags like supranuclear gaze palsy, cerebellar signs, early severe autonomic involvement, Lewinsky sign, early severe dementia. Then MRI findings suggestive of hydrocephalus and many other MRI findings that may suggest Parkinson plus syndromes. The third step is to see for any supportive criterias, like, of course, the most important is the unilateral onset, the resting tremor, progressive, it is a progressive disorder, and the asymmetry persists even when the other side is also gets involved. There is excellent response to levodopa, and then you also, the patient also complains during the course of treatment of levodopa-induced dyskinesias. Uh, And levodopa response persists during the honeymoon period, which may last for 5 to 10 years. Now, coming to the differentiation between the essential tremor and Parkinson disease. In essential tremor, there is a bimodal onset of the age. You see the age group, the initial younger age or the elderly, 80 years and above. Parkinson is mostly seen in 60 plus 60 years and above. Family history is mostly seen in essential tremor. Frequency again is a differentiator. You can see 4 to 6 hertz in Parkinson's disease and essential tremor, it is more. The characteristic of tremor is again important, which is pronation, supination kind of tremor in Parkinson, while it is flexion extension kind of tremor in Fisher. The influencing factors are more important. That is, in Parkinson disease, tremor is mainly a resting tremor, whereas essential tremor diminishes on rest. Action increases the essential tremor while it diminishes the Parkinsonian tremor. Then walking again increases the Parkinsonian tremor while it decreases the essential tremor. Alcohol has a positive impact on essential tremor, and tremor of asymmetry is definitely a feature of Parkinson tremor than it is of essential tremor. Then if you have a voice tremor and a head tremor, that points towards the essential tremor, and face, jaw, lip, and chin tremor can be seen in patients of Parkinson tremor. There is a subset of patient where you may get an overlap. Patient may have essential tremor and over the course may develop symptoms of PD. In this, you may find bradykinesia. Patients may have olfactory deficit. There may be family history. There may be mild dopaminergic deficit in DET scan, and this may be labeled as benign tremulous Parkinsonism. DET scan does help in differentiating if you are not confident about differentiation between the essential tremor and Parkinsonian tremor. Although clinical evaluation is sufficient to differentiate, but sometimes in difficult problems, you can take a help of DRODET scan. In a normal or an essential tremor patient, you will find symmetrical normal uptake of dopamine. And in a typical Parkinsonian patient, you will find bilateral and typical asymmetry on one side. Then drug-induced taking a history is so much important. We have seen patients with levosulfide, antipsychotics, sometime with flunarizine and often with tetrabenazine, presenting with Parkinsonian symptoms, usually evolving over 1 month to 3 months time after consuming these drugs. And treatment would include the tapering or stopping the medication. In case of antipsychotics, we prefer clozapine and quetiapine. Treatment would consist of first, of course, stopping the medication and using the anticholinergics or amantadine as a possible treatment option for these patients. Normal pressure hydrocephalus again is a mimicker, often receives levodopa thinking that it is a Parkinsonian disease. But you may find bradykinesia, but there will not be a cogwheel or tremors in patients of NPH. The usual stance is wide and outwardly directed, where it is narrow and inwardly directed in Parkinson's disease. And it is usually not responsive to levodopa or less responsive to levodopa as far as NPH is concerned. Then, of course, CT scan or an MRI is again a supportive evidence for NPH, where you can see the Evans index, which is the ratio of the maximum width at the frontal horn and the maximum internal diameter at the of the internal table. And it is more than zero point 0.3, then it favors the NPH. Similarly, the callosal angle, if it is between 40 to 90 degree, it favors NPH. Then you can do a CSF flow dynamic study where aqueductal or fourth ventricular flow void would suggest that patient would benefit from the patient. And Parkinson plus syndromes, obviously, you need to rule out whenever you are dealing with a patient with Parkinsonian type of presentation. If there is a early history of frequent falls, and you find a vertical gaze restriction, then it points towards PSP. If there is a prominent orthostatic hypotension, then it points towards the multisystem atrophy. Uh, Early dysarthria, again, multisystem atrophy cerebellar type. Hallucinations or dementia as a first early onset points towards Lewy body dementia, aligned limb phenomena towards the cortico-basal degeneration. So you suspect Parkinson plus syndrome when you take a history of all these features. Then sometimes you do take the help of an MRI, and in case of PSP, you can clearly see the difference from the normal MRI to the affected patient MRI, where there is a significant atrophy of the midbrain, and this is known as hummingbird sign. And in case of MSA, T2 axial sequences, you can see the T2 hyperintensity in the form of a cross, which is known as what cross-bun sign. So what are the red flags? If there is a rapid progression requiring use of wheelchair within the 5 years of diagnosis, often think of multisystem atrophy or PSP. And if there is no motor progression for 5 years, then obviously it would point towards, and patient is having predominantly tremors, then it would point towards the essential tremor. Early bulbar dysfunction like dysphonia, dysarthria, or dysphagia would suggest a multisystem atrophy. Uh, Strider would suggest again a multisystem atrophy pathology. If there is a severe autonomic failure within the 5 years of diagnosis, in terms of hypertension or urinary incontinence, would again suggest a multisystem atrophy or dementia of Lewy body. Recurrent falls again point towards PSP. Absence of non-motor symptoms mainly seen in essential tremor. Bilateral symmetrical disease from onset usually point towards Parkinson plus syndromes. This is how you grade the severity of Parkinson disease into 5 types. Unilateral involvement, bilateral involvement without impairment of balance, mild to moderate bilateral disease with some postural instability but physically independent. Grade 4 is severe disability but still able to walk or stand unassisted. And stage 5 as uses wheelchair or bedridden. Coming to treatment, it's basically a symptomatic treatment, but it can be started as early as possible because studies demonstrate that patients' quality of life deteriorates quickly if you don't initiate the treatment early. The levodopa is the gold standard, and coupled with carbidopa, which is a peripheral carboxylase inhibitor, remains the gold standard for symptomatic treatment of Parkinson's disease, and it provides greatest anti-Parkinsonian benefits for motor signs and symptoms. However, its long-term use is associated with the development of motor fluctuations and dyskinesias, and which are often difficult to resolve. Patients often complain of nausea and vomiting, and so you can advise them to be levodopa is usually taken empty stomach, but they can take it after a small non-proteinaceous meal. Additionally, you can give extra dose of carbidopa like Syndopa Plus, which has 25 mg in place of Syndopa 110. And of course, you can add domperidone. The other side effects of levodopa are the most problematic are hallucinations, restlessness, psychosis. Now, there is a debate regarding why, when, and how to initiate the pharmacotherapy in Parkinson's disease. And there has been usually a debate whether we should start levodopa early or late. Now, concerns about the development of motor complications arise from early initiation of levodopa led to this levodopa sparing strategies, but it has been largely mitigated by the outcome of PD-MET and levodopa in early Parkinson's disease or a LEAP studies, which has shown that there is a definite potential for early improvement in quality of life when you start early. And it is not always the duration of levodopa therapy that is related to motor complications, but rather the disease progression itself. In addition, levodopa does not seem to have a negative impact on the progression of disease. The second group of drug are the MAO-B inhibitors like selegiline and rasagiline, which are irreversible MAO-B inhibitors and considered for initial treatment of early disease. And these drugs provide mild symptomatic benefit, and it has been found that they can improve the long-term outcome and of the quality of life indicators by 20 to 25%. Then safinamide is again one more reverse. It is a reversible MAO-B inhibitor, which is having both dopaminergic and non-dopaminergic, that is glutamatergic properties, and it has been approved for the treatment of mid to late stage fluctuating Parkinson's disease as an add-on therapy to a stable dose of levodopa alone. Safinamide is usually used as in 50 to 100 mg per day doses, and it has been found to significantly increase the daily on time without dyskinesia in patients with mid to late stage Parkinson disease with motor fluctuations. So while selegiline you can use in early stage, safinamide is something which you can use mid or late disease Parkinson disease along with syndopa. And it does not cause new or worsening dyskinesias. So that's an additional plus point. And evidence suggests that safinamide is a good option for an add-on therapy along with levodopa, carbidopa in patients with advanced PD with motor complications. The only problem is hepatic dysfunction, and it, of course, in a young pregnant woman, you should not use. And current use of MAO-B inhibitors and SNRI and tricyclic antidepressants should be avoided. Dopamine agonists are synthetic compounds that act as agonists to D2 receptors within the CNS and thus mimics the function of dopamine. The currently FDA-approved agents include pramipexole and rapinirole, then as a skin patch, rotigotine, and as a sublingual film or a sublingual tablet, apomorphine, and as a subcutaneous injection, apomorphine. The side effect profile of dopamine agonists include nausea, edema, leg edema, orthostatic hypotension, sleep attacks, and impulse control disorder, which impulse control disorders are more problematic. And whenever patient develops this reduction in the dosage of dopamine agonist is warranted. And if you suddenly stop it or suddenly reduce the dosage, there can be a dopamine agonist withdrawal syndrome characterized by agitation, anxiety, depression, fatigue, and autonomic symptoms including orthostatic hypotension. So you should do it in a gradual manner. The next group of agents are anticholinergic agents. It can be used in patients who have disability due to tremor. So it's a predominantly tremor related presentation, then you can use anticholinergics. Otherwise, they are not the first line of agents to be used. They provide good tremor relief in approximately 50% of patients only and do not meaningfully improve the bradykinesia or rigidity. The commonest used is triaxiphenidil. You can start with a smaller dose and gradually build up the doses, uh, keeping in mind the adverse effects, which includes memory difficulty, dryness of mouth, confusion, and hallucinations. Amantadine, again, an old drug, NMDA receptor antagonist approved for the treatment of PD in 1973, and its extended release form now available was approved for treatment for levodopa-induced dyskinesias. It causes release of dopamine and norepinephrine from storage sites and inhibit the reuptake of dopamine and norepinephrine. Offers additional benefit in patients experiencing maximal or waning effects from levodopa. The common side effects, of course, again, would be hallucinations and orthostatic hypotension, peripheral edema, and constipation. Then non-motor symptoms are very important and should be searched for. They often present early, even before the motor symptoms, and how to treat them again is important because they do require treatment. The common non-motor symptoms that we associate with Parkinson's disease are depression, in which, of course, SSRI and SNRI are often used. But whenever you are using these agents, do not combine with MAO-B inhibitors. For apathy, you can use pyrimidine and rivastigmine. Hallucinations and psychosis is very common in late stages of Parkinson disease, and the recommended approved treatment is pimavanserin, although it's not available right now with us. So we are doing with the clozapine and quetiapine, mainly quetiapine, as quetiapine is not a dopamine blocker. Then impulse controlled disorders related to dopamine agonists. Of course, you have to gradually withdraw the dopamine agonists. Moderate to severe cognitive impairment can be seen even in early stages, and so you can give cholinesterase inhibitors and NMDA antagonist. Orthostatic hypotension, you may use midodrine and fludrocortisone. Uh, Urinary retention incontinence, of course, urinary incontinence is very common with patients of Parkinson's disease, but you have to differentiate between NPH and Parkinson's disease. And solifenacin is commonly used in patients who complain of urinary incontinence. Uh, ED, of course, sildenafil and then other drugs are there. Constipation is very common and often difficult to treat. Lubiprostone and high fiber diet is one option. You can use lactulose also and linaclotide. Uh, Excessive sweating is reported in late stages. Anticholinergics can be used. REM or RBD disorder, sleep behavior disorders, can be treated with melatonin and clonazepam. Uh, Sleep fragmentation or insomnia, if a patient complains, you can use rotigotine skin patch and melatonin. Excessive daytime sleepiness, modafinil is a favorite drug. Pain, of course, is a common problem in patients with Parkinson's disease, and you can use cephinamide, oxycodone, and the common painkillers and opioids as well sometimes. Fatigue, you can use MAO-B inhibitors like rasagiline. Olfactory dysfunction, of course, you can't help it. So, symptomatic anti-Parkinson medications usually provide good control to most of the patients of Parkinson for 4 to 6 years, which is usually known as a honeymoon period. Beyond this, as this disease progresses, the disability often increases despite the best medical management, and many patients develop long-term motor complications, including fluctuations and dyskinesias. Uh, So obviously, this is the time when the real challenge of treating these patients come. And so how to manage the patients with advanced disease, where the patients have motor fluctuations, and the spectrum of motor complications would include end of dose, wearing off phenomena, unpredictable off, peak dose dyskinesia, suboptimal on, no on, and off dystonia, stage dystonias. Wearing off is fairly very common after several years of using levodopa. Many patients notice that they benefit from immediate release levodopa, carbidopa wears off within few hours of using it. And over time, this shortened duration of response become more fleeting, and clinical status fluctuates more and more closely in concert with the peripheral levodopa concentration. So as the CNS buffer of dopaminergic neurons deplete, so the level of the buffering effect of the remaining dopamine also goes off, and then whatever levodopa we are giving the body responds to that, and then motor fluctuations develop. So what are the possible strategies when you deal with patients with motor complications? One, of course, is that you can add a dopamine agonist, or you can add a COMT inhibitor to prolong the effect or duration of the action of the levodopa, or add a MAO-B inhibitor. You can use levodopa in frequent dosing with a shorter interval, or you can increase the levodopa dose provided the patient is able to tolerate it. Uh, then switching from immediate release to a sustained release preparation like Syndopa CR or using a COMT inhibitor is a strategy. Then duopa, or a continuous intrajejunal infusion of a carbidopa, levodopa, intestinal gel, which is available in US. We may be able to use it in a near future. This is usually given through a PAG insertion. Then in January 2015, FDA approved carbidopa, levodopa, this duopa that I am talking about. It can be given in jejunum through a portable pump. And the efficiency or efficacy of this central suspension has been clearly shown in the multi-center study. Then other options could be subcutaneous apomorphine. The usual starting dose is 0.2 ml or 2 mg and adjusted based on the clinical response. The common side effects are nausea, vomiting, somnolence, dizziness, and rhinorrhea, and postural hypotension as well. Sublingual apomorphine sublingual formulation is also available. It consists of two layers of thin film developed to maximize the delivery of apomorphine and avoid the local side effects. Subcutaneous infusion of apomorphine is also a possibility in these patients of difficult to treat Parkinson disease. And it has been shown to increase the on time without troublesome dyskinesias and reduction of levodopa dosage. But before giving apomorphine, you need to do a apomorphine response test. This is how you do. You evaluate the patient's baseline status of the Parkinsonian symptoms. And of course, you have to pre-medicate the patient with domperidone to avoid nausea and vomiting. And then you gradually increase the dose. You start with 1 mg subcutaneous. Over a 10 minutes period, you see, again do the clinical assessment and check for any postural fall in the blood pressure, nausea and vomiting. And if the patient is able to tolerate, then you can increase the dose as per the response visible. You can go up to 6 mg or the dose that patient can tolerate. Then you have a rotigotin transdermal patch, which is a non-ergot dopamine agonist, which is highly selective for D3 and D2 receptors. The use of silicon-based patch offers 24 hours delivery of drug and avoids the side effects of pulsatile delivery of levodopa. The most common adverse effects reported are nausea, somnolence, local site reaction, and dizziness. And the incidence of dyskinesia with rotigotin are very low or mild. Then this, of course, have been discussed, the intrajejunal infusion through a PAG insertion. Then extended release, we usually use this Syndopa CR preparation, and it contains 1/3 of the immediate release formulation and the 2/3 the extended release, and especially useful in the overnight before going to sleep, so that the early morning dystonias or dyskinesias can be avoided. Cefinamide, again, a good option for mid to late disease stage Parkinson disease patients. Inhalation levodopa available in US but not here, has been approved in 2018 as a rescue medicine for patients of advanced Parkinson disease. Then defilanin is a selective adenosine A2A receptor antagonist, has been approved as an add-on therapy to carbidopa, levodopa for the treatment of off periods in patients with late PD. Dyskinesia is, of course, the major issue with levodopa, as the you start using over the years levodopa, you find patients developing peak dose dyskinesias, which are characterized by coriform movements, which is twisting and turning movement that occur when levodopa-derived dopamine levels are peaking. And besides these coriform movement, you can also have bellesmas, dystonias, myoclonus, or a combination of any of these movements. Uh, if you have peaked dose dyskinesias, if you increase the dopamine level, then of course it can worsen these dyskinesias. And once you decrease, it may increase the motor problems associated with decreasing the dopaminergic levels. So there is a narrow therapeutic window within which you have to work. These are the three commonly seen dyskinesias that we see. And in peak dose dyskinesias are the most common. And what to do if you have peak dose dyskinesias, you can decrease the individual dosage of levodopa. The other thing that you can do is to discontinue or reduce the COMT levodopa combination, or you can if you are using MAO-B inhibitor, you can again discontinue it, or you can switch to the immediate release preparation and consider adding amantadine. So these are the strategies that you can do with peak dose dyskinesias. If a patient has off period dyskinesia, which typically occurs in the early morning before the first dose of levodopa and usually involves the leg, what you can do is you can add the long-acting formulation at the bedtime, like Sindopa CR. And if this is the daytime problem, you can consider adding COMT inhibitor or a MAO-B inhibitor or a dopamine agonist. The third, the least common, is the diphasic dyskinesia, which starts when you administer levodopa. Within 10 to 15 minutes of levodopa ingestion, you may get dyskinesias in the ipsilateral leg movement, and which can then involve the contralateral side. Uh, and this dyskinesia recurs when the levodopa level declines. So it's a diphasic that at the starting of the levodopa ingestion and when the levodopa effect weans off. It's often difficult to treat, and the only options available would be this levodopa carbidopa intestinal gel infusion through a PEG insertion, and the apomorphine, often used as a rescue medicine. You can use as subcutaneous infusion or as an infusion pump, or you can go for a surgical interventions like deep vein stimulation. A surgical treatment would be taken by Dr. Amitabh Goel. Just a brief passing reference. Four types are there. Started with ablative therapies, surgeries like thalamotomy, pallidotomy, and subthalamotomy. Then in 1987, deep brain stimulation started, and then subsequently the trials clearly showed the benefit, and this is the preferred choice of surgery for patients of Parkinson disease. Then MRI guided focused ultrasound is another thing, which is a kind of lesionectomy and is being approved only for to be used for one side only. Similarly, like stereotactic radiosurgery, which can also be used on one side only. Uh, we as neurologists have to select patients for DBS. So before referring for DBS, we should be confirmed that we are dealing with Parkinson's disease, who is levodopa responsive and continues to be levodopa responsive. There is a good on function while he is on medication, and but he has symptoms which are not adequately controlled, like dyskinesias or motor fluctuations. Refractory tremor again is a indication for DBS. Then frequent or severe off periods, and these off periods increase the disability of the patient. Then you of course have to go for DBS. Plus, you have patient who can have a realistic expectation out of surgery. You also need to rule out the red flags and those who have do not adequately respond to levodopa, and uh, patients with cognitive decline are not suitable for DBS. Similarly, depression and psychosis. MRI guided focus ultrasound was approved by FDA in 2016 for treatment of unilateral essential tremor, PD tremor, and PD related dyskinesia. Basically, it contains of a transducer which emits ultrasound beams and result in ablation by thermal coagulation when focused on a target. Used as a way of in those patients who do not prefer DBS surgery and have a predominant unilateral symptoms. Stereotactic radiosurgery usually uses an externally generated ionized radiation to target a specific site. So it's basically a lesionectomy, which can be done for VIM in patients with tremor predominant symptoms and GPI or STN in those with motor fluctuation. So finally, to conclude, the diagnosis is mainly clinical based on history and neurological examination, and you need the support of that only to differentiate between PD, essential tremor, and or drug-induced Parkinsonism. In patients with early PD, the goal of treatment would be to alleviate symptoms and maintain independent functions. There is a clear-cut recommendation to start early, and you can start levodopa also early. There is no guideline to delay initiating levodopa. In advanced Parkinson disease, the focus is aimed towards maximizing the on time, minimizing the off time, and treating the medication related complications like dyskinesias. Surgical options would include the preferred option, of course, is DBS, and would also now include MRI guided focus ultrasound with predominantly unilateral symptoms who do not want to undergo a surgery. Thank you.
Thank you, sir, for nice and elaborative talk. We will take question and answer session after the second talk by Dr. Goel, sir. So I request our second chairperson, Professor Nityanand Gopal, sir, to please take the dais and introduce Dr. Amitabh Goel, sir.
Thank you, Dr. Arvind, for giving me the opportunity. Dr. Amitabh Goel has been practicing a neurosurgeon since 1997. He finished his MCH training. Am I audible?
Yes, sir, you are audible.
He finished his MCH neurosurgery from SGPGI Lucknow in 1996. He was then faculty at Himalayan Institute of Dehradun and then at Apollo Hospital, New Delhi for more than a decade. For the past several years, he is Senior Director and Unit Head of Neurosurgery at Max Hospital, Padpadganj, East Delhi. He has, to his credit, national publications and has co-authored a chapter on subarachnoid hemorrhage in the textbook of emergency medicine. A pioneer in transnasal endoscopic surgery for pituitary tumors in North India, he has been holding the lecture. Hello. He has been holding the lectures and orations all over the country since 1999. The topic that interested him most are the endoscopic minimal invasive spine surgery, the CV junction surgery, and the microvascular neurosurgery. Dr. Goel is also an active member of the Neuroendoscopic Society of India, and he is a member of International Federation of Neuroendoscopic Society. Now over to Professor Amitabh Goel.
Am I audible? Good evening, everyone.
Yes, sir. Yes, sir, you are audible.
Thank you, Dr. Gopal, for the kind words. And I'll share my screen, so please permit sharing of screen because I have not prepared a PPT with the your screen sharing. So I'll go straight away to my. Is my screen on?
Yes, sir.
So I'll take you very quickly to Dr. Vivek Kumar has wonderfully described everything about what Parkinson disease is about and including some part of the history. So I'll straight away just the overview, and then we please feel free to intervene, and if you have any questions. So these are the main targets for the subthalamotomy, pallidotomy, or thalamotomy for surgical treatment of Parkinson's disease. And treatment options are typically done by a multidisciplinary team consisting of a neurologist, surgeon, psychologist, and sometimes a physio also. And DBS has become the most widely used surgical therapy, although there is a re-emergence of MRI-focused ultrasound, like it was mentioned earlier as well. So what are the current surgical treatments? These are the targets for the DBS, STN, and the GPI. And after STN, DBS, dopamine replacement medications can generally be reduced. So this is the basic difference between these two targets, that with STN, you are able to reduce medicines, better reduce medicines. And with GPI, you have fewer cognitive and mood-related side effects. So it will depend upon person to person which kind of side effects the person has been having when on treatment. Other radiofrequency and radiosurgery pallidotomy, these are lesionings. So we are discussing DBS, and then we'll take a word about lesioning as well. So this is the history of radiofrequency and radiosurgical pallidotomies. Lesioning procedures are done for those who decline or are poor candidates for DBS. Focused ultrasound thalamotomy for essential tremor has led investigators to lead highly selected tremor predominant Parkinson's disease with aqueous thalamotomy, when the tremor is the main component. Lesioning procedures are not reversible and thus are primarily performed unilaterally for obvious reasons, and limiting its effectiveness in bilateral disease process. So lesioning being an irreversible process is usually not preferred nowadays. But like I said, has to be done in people who are not fit for, or can be tried in people who are not fit for DBS procedure, or for financial reasons. This procedure is still being carried out. So when do you consider a person for surgical therapy? Dr. Vivek has wonderfully pointed that out as well. So medication, when the medication is not getting tolerated, or the patient has become refractory to that, or the time period has reduced to a significant effect time, like for 4 to 6 hours, it has come down to 2 hours or less, and patients who cannot be managed by oral medications alone. So what about pre-surgical evaluation? Basically means that once the team has decided that this person is fit for, before deciding, you have to confirm the diagnosis, review the appropriateness of oral medication trials, assess motor and non-motor symptoms, family expectations, and neurocognitive and psychiatric profile has to be assessed. And neuroimaging, basically like a Tourette scan, on and off levodopa challenge, and the surgical risk have to be explained to the family in detail. And interdisciplinary conference to review patient factors to determine which surgical therapy is appropriate, which means that what would be the target? Would it be STN, GPI, or something else? Is it going to be bilateral or unilateral? Is it going to be staged versus simultaneous? Which means that some people put in one lead at a time, so the battery is inserted in one go, but one lead is put in on one side and the other lead is put in on the other side after some time, which means sometime means few years later. The type, which means awake versus asleep, and the type of lesioning procedure, if lesioning is being targeted. Awake, most centers do awake, which means we'll come to that in detail. Asleep is only for those who cannot absolutely undergo a awake surgery. So this is again, I think, a repetition of the same thing. So yes would be for patients with idiopathic Parkinson's disease with levodopa-induced motor complications or medication-refractory tremor. And no would be atypical Parkinsonism, postural instability, supranuclear palsy, yes palsies, and dysautonomia and dementia, obviously. So which is a better target for which person? So the two main targets are the GPI and the STN, subthalamic nucleus and the globus pallidus interna. Meta-analysis 2019 found that similar efficacy for both in long-term tremor suppression, and both targets significantly reduce levodopa-induced dyskinesia. So both targets are equally effective in managing both these main issues, although there are some differences. Like for GPI, stimulation can have greater anti-dyskinetic effect. So dyskinesias, which is a problem with medication, you can target that person with GPI stimulation. And with STN DBS, you have consistently been associated with greater reduction in the dopaminergic medication, which means patients who are having side effects of dopaminergic medications, you would rather do a STN DBS for that patient. Reduction in medication dosage can reduce the dyskinesia, drowsiness, compulsive behaviors, orthostatic hypotension, and hallucinations. So that is why it is sometimes important to differentiate which patient needs which. Most people benefit with STN. It is safer to do, it is easier to do, and gives you better results in the short term. Longer term results are better with GPI. So another question is it unilateral or bilateral? So most centers perform bilateral, like I also do bilateral only. I've never done a unilateral because unilateral doesn't change anything. It doesn't reduce the cost, and you can always stimulate only one side. If you're stimulating only one side, then you can start stimulating the other side if the symptoms appear later, maybe 6 months later or a couple of years later. And for older patients with those with predominant one-side symptoms, unilateral DBS may be considered, but only for very limited indications. It has definitely shown to improve motor symptoms and quality of life with greater benefit with the GPI. So what hardware would you want to use? Which means that this is a picture of the leads. This is the oldest one. This is the oldest one. So the black is the silver is the stimulating area, and black is the covered area. Sorry, silver is the covered area and black is the stimulating area. So this is the oldest design. Now the length of the lead was then increased. Then you have directional leads. I will tell you what directional leads are. Basically means that you can have an area of stimulation which is only in one direction. Like for this lead, the whole black thing exposed will stimulate all around, while this would stimulate only in one direction and this black would stimulate only in that direction. So these are three cuts made in the insulation. So you have 120 degree each out of the 360 degree coverage. With the stimulation of individual or a combination of segmented electrodes, the current can be steered. It can literally be steered in a particular direction, which is called directional stimulation. And newer devices allow constant current stimulation, which means the previous one, like this one, was for constant current stimulation. Now, after directional, you can have a combination of any of these, which means multiple independent control in which each electrode has a dedicated current source. The battery remains the same, obviously. It's got 12 12 connections on each side, right and left. So you can play around, and that's how the time programming of the final programming of the device takes time, because you have as many number of combinations to try. These advancements have enhanced programming capabilities by enabling complex field shaping. I'll show you what a field shape is, to avoid stimulation-induced adverse effects and optimize clinical benefits, but also have increased the amount of time clinicians. So what I'm saying, that programming has become more complex, but it has become better for the patient. So what is the surgical procedure? So very quickly take you through this. So the patient has been so this is the drape. This is the drape. Come back to this. This is all drape. The patient's face is here with the oxygen mask. This is the frame. Obviously, the CRW frame or the Lexel frame, whatever frame is being used by that company. The patient is awake. There is no tube in, just breathing. The eyes are exposed, and the light that you see here on the patient's face is coming through the IO band that I have put here. It's been draped. So this is the foot end, this is the head end, and the light, OT light, is shining through onto the patient's face. So it is clearly visible, not very clearly visible to the surgeon, but then the attending person, who is usually a neurologist or company person, who would look for the, or the anesthetist, who would look for dyskineas, eye movements, extraocular movements, whether nystagmus is appearing or not, or these stimulation things would be seen live once the electrode has been put in. I will show you in a minute. So this is how a bicoronal incision is made, and this electrode has been inserted. The first slide is actually this one. So these are the values, the coordinates which have been fed. Incision has been marked, and this is the frame here. Once the incision has been made, then you so this is a short clip of what it looks like. The frame has been mounted. The equipment is used to exactly target the whatever we have planned for, the STN or the GPI. And this is a super zoomed video of the same thing, where the microelectrode recording is now going on. These wires are, I'll pause for a second. These wires that you see, usually 3 are put in, sometimes only 2 if you get very good recordings in 2. So each wire is 0.1 millimeter, which is 100 micron in diameter. This is a 1 millimeter mark that you see on the frame. So you can imagine that this is about 1/10 of this. So these electrodes are then passed to the brain, and a microelectrode recording, I'll show you what it looks like, is done. And it is visible on the laptop. This is a short clip of what the electrode recordings looks like. It is a work in progress, because not everybody is trained to hear and see the recordings. So the company person and you also can get trained yourself to look at these recordings, so that you can also train yourself to look for any correct recording. Each nucleus has its own pattern. It is fed into the laptop, and that's how you see. So this is, I was talking about the directional, full screen. These are the directions, like this one is the standard one, the old one that I said, 4 exposed areas, and this is a cross section of this. So if the lead is in the center, the volume of tissue activated, VTA, the VTA is constant around it, which means in all directions it will stimulate equally. But if you have a directional lead, which means that it is exposed on one side while it is not exposed on the other, so the stimulated area will be more on one side, will be less on the other side. So these are, you can have other frequencies also, like for 60 microsecond at 120 microsecond at 60 hertz. And these are the various variables that you can choose. So that's why programming it takes a lot of time. And I'll come to the patient clip just a little bit later. So there is a technique called non-invasive DBS also, which means that although it is a work in progress, it is it works by offsetting the non-physiological high frequency stimulation, which is very high, 2 kilohertz, 2000 hertz, not like 60 hertz. So this was done in rodents, and the future means that technology could theoretically enable non-invasive test stimulation mapping or for lesional experiments. So coming back to usually we have stereotactic frame-based surgery. Sometimes I also perform awake surgeries with intra-physiological mapping, including MER, microelectrode recording that we just saw on the laptop, and microstimulation also is done to look for the whether the lead has been placed at the appropriate place, which means once the MER has been put in, microelectrode recording has been put in, and you are happy and satisfied that you have hit the target, then you remove those electrodes and then put the final electrode, the shape of which we saw on that picture, exposed at 4 points or directional, whatever you decide to use beforehand. So that lead is inserted in that same track from which the MER recording was done, and then you stimulate, because this lead will not record. It's a very big lead, so it will not be able to record anything, but it can stimulate the tissue at which it has been placed then. So once the stimulation is started with using the same laptop, it is not yet connected to a battery. So once that happens, then you can look for the side effects of the stimulation, if there are any, and for obviously the positive effects also. It may not be very accurate to say that you will get the same effect in the same sitting, because once the MER electrode has been removed and stimulating electrode, a fair big size, it's about 1.8 millimeter in diameter, has been introduced, then it causes some lesioning effect also, which means it has actually hit the brain, a very sensitive area of the brain, and it would help, it would obviate and it would mask the effect of the stimulation. So once that tissue is stunned, it is sometimes difficult to exactly show you the correct response to the stimulation. So the stimulation thing would happen only later on. So once you have seen that there are no major dyskinesias or nystagmus or facial deviation or ectotoid movements, once the lead has been reasonably stimulated to usually less than 1 volt in the first sitting. So once this has been done and you are happy that the lead has been optimally placed, then you start closing everything after the connections have been made. Small risk has been hemorrhage, which is very 1% chance of having some hemorrhage which would cause lead displacement will not cause any major issues. The software that is used to introduce the needle into the, I don't have the MRI images with me, but then the software which helps us guide the trajectory, like you can like this is the whole thing. Where would you want to enter from? So the point here, that is usually, that is decided by following a trajectory of planned trajectory using that software, which tells you whether the probe that you are going to put in, the electrode that you are going to put in, would hit any sulcus or not, would it hit a ventricle or not, would it hit the capsule or not. So this is these things have to be cancelled, which means the electrode should not be passing through any of those. Should be it would obviously enter through a cortex. You would not want to through a sulcus because the vesicle virus is seen before this, and show you this after the leaving place. The patient is taken for CT scan. If there is no hemorrhage, then the corresponding this plant trajectory in the blue one, right and left, and lead, the beam heart rate of the lead is naturally following same. So this CT scan, stop CT scan, while the patient is still the scalp has just been partially closed, not fully closed, and the battery has not yet been CT scan to rule out hematoma and trajectory.
I think there's a problem with connectivity of Dr. Goyal, sir. Network issue, I think. Sir, Sir, you are not audible, Amitabh sir. Yes, sir. Well, sir, you are not audible. Amitabh sir, you are not audible. Sir, you are not audible. You are visible but not audible.
Can you hear me now?
Yes, sir. Now you are audible.
So I'll share the screen one more time.
Yes, sir.
I don't know when did I lose you guys. So screen sharing. So my screen is not visible yet.
No, sir. You are not visible.
I'm not able to choose entire screen. Okay. Is it visible now?
Still not,
The
sir.
screen is not visible.
Yeah, no, sir. Your screen is visible, but
No. Is it showing your this thing or my presentation?
sir, it is not showing a presentation. It is just showing Zoom.
Time. Let's go to. For me, it is saying you are screen sharing. So if it is, maybe I stop share and then start again. Share. Screen sharing is on.
It's again same, sir.
Is my desktop visible? No.
Your desktop is visible.
Desktop
But
is
it is
visible.
showing- Yes, sir.
Okay. Can you see now the files?
Yes.
Okay. So we were talking about the surgical procedure. And like I said, most centers do awake craniotomy, awake surgeries with MER recording. And on top of that, we do a check CT scan, which I just showed you. And so we go back to the closing statement, which means that what are the recent advances? I'm skipping the lesioning thing because the topic I didn't realize was limited to DBS. If you want, we can talk about radiofrequency lesioning here. So this involves, again, neuroimaging, stereotactic frame, RF generator, thermally induced lesion is made. These are the targets: VIM for tremor predominant, and thalamotomy. And UPDRS is the gold standard method for checking the response to whatever therapy is being given. Adverse effect of palliatotomy include visual field deficits, and obviously the risks remain the same: hemorrhage and infection. I'm skipping the target selection. I'll go straight to just a couple of videos which show the response of the patient to what we have done. Like this patient, is the video seen? Can you see the video?
Yes.
So this patient has been implanted with a DBS device, but the machine has been switched off for demonstration purposes. She really was in a very bad shape. She had severe bilateral tremors, right more than left. She had to literally hold herself together. And this is within about 30 seconds later that we switched it on, and her movements had then become smooth. So this is with the DBS on, and although she is still in a chair, the movements are now. This is about a month after her procedure had been done, and bradykinesia improved to some extent by about, let's say, 50%. But then tremors which were her major concern, did almost disappear, and she was able to eat herself, feed herself, and clean herself. So you can have magical responses to this. I'll show you a screenshot that the patient family sent to my PA saying same problem. This person sending is a dentist. This is her mother that we did last month, and she's really fond of her dance classes. So she plans to go back to her dance classes very soon. You see a very good patch of hair on her head. You see a good patch of hair on her head. That's a wig that she got made out of the same hair that I had given back to her after the whole head was shaved for DBS. The whole thing has to be shaved for infection control purposes. She got those made, and this wig was made within a week, 10 days. And this she sent with this video, I think about 15 days, 18 days after the So sometimes these procedures are, fine movements have significantly improved, and taking you very, I'm stopping the share here because I don't think it is needed. The next step that is coming is the feedback from the patient, which helps program the leads and the electrical current, which means that if somebody is wanting to eat food and wants a particular directional current, so a wearable sensor will tell the battery that uh, that particular electrode is to be stimulated so that you have control more over the right hand. So those things feedback. Most equipment now are closed loop, but open loop systems are being developed, which will involve third party hardware as well, which are wearable. So I'll close my talk here. Questions are welcome, please. Thank you.
Thank you, sir, for nice and elaborative talk on DBS. This is something very new for your videos are new for us. So the session is open for question and answers. If any question is there. So I have one question from Dr. Vivek Kumar sir, who has discussed medical management of Parkinson's disease. Sir, I would like to ask you about start of levodopa in young onset Parkinson's disease. Do you suggest starting levodopa from start, or do you suggest starting dopamine agonist in these patients? Because dopamine agonist has a lot of side effects, lot of psychological and other psychiatric side effects in long term. So what do you suggest? Starting levodopa from from the outset, or start with the dopamine agonist?
Am I audible?
Yes, sir.
I would prefer starting levodopa because it has the best response. And so a young patient would require a drug which can improve his quality of life. And obviously, the tolerance of levodopa in younger age is a problem, and the early development of complications. But still, the drug of choice would be levodopa rather than starting dopamine agonists.
So I think this theory has been changed. That start DA dopamine agonist in young patient, and then start levodopa later on for having the dopamine sparing effect.
Yeah.
So I think this theory has been changed now. So one should start with the levodopa from the outset.
Yeah, as I said, the studies have shown that there is no advantage of delaying the levodopa initiation. If you start early, you can improve the quality of life better because the effect of levodopa on the Parkinsonian symptoms are more marked than that of by the dopamine agonist. Plus, dopamine agonist has one problem of impulse control disorders,
Yes.
which if developed, then you have to withdraw.
Yes, yes.
So that is a problem.
So any other question from the audience? Sir, Mora sir.
Excuse me, sir. I am not one of you, but I got this link and by Dr. Yasin Gupta. I am a doctor in Ludhiana and my husband is a surgeon. He is suffering from Parkinsonism for last 15 years and he had been on this Syndopa, Carbidopa, Emmentrol, Primipex, all these tablets. And I just want to know, but recently he has developed so much dyskinesia. And my neurologist here, he keeps telling me to stop Emmentrol and Primipex. But the moment I stop Mentrol, he becomes very slow. Everything, he develops bradykinesia, and I mean, every movement is very much slowed down. So I will really like to know from Sir Vivek that what should I do? Should I stop Mentrol? Should I stop Primipex? Because I'm giving the Syndopa, Carbidopa 4 times a day, starting from 7 a.m. to 7 p.m. till evening. Every 3 hourly we have to give him. So he's doing well with everything except these problems of dyskinesia, and of course, some dementia is setting in and some psychiatric problems maybe. So please, can you guide me?
Good evening, ma'am. Good to see you.
Good evening.
Basically, dyskinesia are more commonly seen with levodopa. Amantadine doesn't cause dyskinesia. In fact, it is used to treat dyskinesia related to levodopa. So I don't think any reason to stop amantadine. It should continue. What you can do, you can increase the frequency of use of levodopa. You can use it in a smaller frequent doses, because basically it is related to the pulsatile stimulation by levodopa. So the dyskinesias are obviously like that. So dyskinesias come at the peak effect or at the end of the dose.
No, they start after 1.5 hours after I give the dose. I start using these, these movements. They all start. Otherwise, if he's sitting right in front of me, he has no tremors at all in the hands or legs or anywhere. The only problem is this kinesia, which starts 1.5 hours after I give him the dose.
So it means they are mostly a peak dose dyskinesias.
Yes.
So basically you can use a smaller dose of levodopa
Okay,
more
sir.
frequently and continue using amantadine. You should not
Okay,
stop
sir.
that.
So previously I had been giving 4 tablets of amantadine, 100 milligrams. But last year, our neurologist, he stopped all the four all of a sudden. And my husband, he literally, he dropped down to zero. So then everybody told me give. So I'm giving one twice daily. But I went to US. My daughter is there. So there also I was told by one of neurologists that stop amantadine and primipex. So I am in a affliction. That is why I
You
wanted
can
to talk to you.
you can also try cefinamide.
Okay. Yeah, I just listened to you. Yeah.
Yeah, so you can also use cefinamide. It doesn't cause troublesome dyskinesias and it improves the motor symptoms, the on time. So it can be combined with levodopa and then you can reduce probably amantadine if it is a problem.
But
So
as such, you think
cefinamide is
amantadine.
one option definitely.
Okay, sir. So then they are also giving the doctor from US told me to give trazodone, and my neurologist in Ludhiana, Punjab, he says give clozapine. So I don't know which drug to give for his.
Hallucinations?
Yes.
Have you tried Qtipin?
No. I haven't tried, but yes, somebody was telling me to give Qtipin.
You can try Qtipin, start with 25 mg,
Okay.
gradually increase depending on the tolerance.
Okay, sir.
Quitipin doesn't cause too much of drowsiness the coming morning, but you can start with a smaller dose, half a tablet bedtime initially, gradually increase the dose. We usually require 25 to 50 mg of quitipin, not more than that.
Yes, sir. Thank you.
And the all these drugs they are associated with hallucinations and problems. So it's difficult. Sometimes becomes a challenge because the moment you reduce the dose, the problem of motor symptoms reappear.
Yes,
So
sir.
you have
Yes.
to use a smaller frequent dosage and try cefinamide as an option.
Sure, sir. Sir, he also has this page here, right in the when we get up in the morning for the first dose, he gives me lots of trouble. So, do you think it is also because of his?
Swallowing, he has a swallowing problem or
Yes.
dyskinesia?
No, swallowing problem. He will just keep the tablet in his mouth or sometimes throw it, or he won't just take it in. So
And have you tried bedtime long standing this Syndopa CR?
yes, sir, we are giving Syndopa CR and Syndopa Plus at bedtime.
Okay, but still morning time he is slow.
Yeah,
His motor
sometimes.
symptoms
Yeah.
reappear.
Yes, sir.
Mhm. You can try liquid Syndopa. Is he able to swallow liquids?
Yeah, he eats full meal. He just had his dinner. But
No, in
in
the
the morning,
morning.
he gives trouble.
Mhm. So we do use liquid formulation. It is difficult to make a solution of levodopa, but in giving liquid levodopa uh, uh, by using in 4 or 5 tablets of levodopa and crush it and add vitamin C and make a solution of 500 ml and use
I
100
did
ml,
that, sir. 1 year back,
100
we did
ml
that.
five times.
Yes.
And
Yes.
if he has a problem with swallowing with liquids also, then of course it's a challenge you can. But during the daytime, otherwise he is able to swallow.
Yes, mostly, sir.
Maybe in the morning.
Most of the time he swallows, but in the morning he gets trouble.
Even with using the long duration
Yes, yes. In
cetirizine.
spite of CR and this carb at Syndopa Plus at night.
Okay.
Apomorphine in the morning,
Excuse me, sir.
a shot of apomorphine.
Apomorphine again is a sublingual formulation is now available in India also. So
Yes, sir.
that of course is again a good option in those who are not able to swallow. Only it causes some amount of nausea, vomiting.
Oh, so
But
that will be another problem. Already, um caretaker problems are arising in me, sir. I have to look after him right from the morning till night. So all this. Uh, Anyways, thank you so much, sir. And I will try that medicine which you told me just now, acetaminide and QT-pen. I will try that.
and also look for this sublingual
Okay.
apomorphine as a rescue.
Apomorph.
Yeah.
Okay, sir. Okay, sir. Thank you so much, sir.
Thank
It
you.
was my, good luck to join this meeting today. Thank you so much.
It's really good that we have a live conversation with the patient in our in our virtual CME. So it's really good. Thank you, ma'am, for joining with us.
Thank you, sir. Thank you, everybody.
So is there any other question from the audience? Sir, comment from the chairpersons.
Very nicely organized and well talked. And the lecture by Dr. Vivek regarding the initially very differentiating from the different type tremors and then dug into Parkinson's disease, then NPH, and then coming to the Parkinson plus syndrome. All these things were really very helpful for the management of the Parkinson disease, and then going through the various the initial phases of the treatment is very smooth, but going to the complications and how to manage them, and then going to the surgical treatment and recent advances like this very fascinating this MRI guided unilateral lesionectomy with high frequency ultrasound, and all these things are very promising. And I think in the near future, the treatment of the Parkinson disease will be quite optimistic and hopeful. Thank you.
So
Please go on.
just wanted to know how many people have used apomorphine and what has been the experience.
So at least in person, I have not used.
Okay.
Still, I'd say it is probably not available in Lucknow or in UP or in small cities. Probably it is not available commercially. It is available only in metros.
Apomorphine injection is available, and I think one company has started marketing this sublingual tablet also.
Okay.
Yes, sir.
So it is basically a rescue medication because it has a lot of problems associated. So once this infusion is available, then it can be used more often. Plus this DOPA, the carbidopa, levodopa intestinal gel through PEG insertion. Once that is available, that is a very good way of providing a continuous dopaminergic therapy.
So, but in the poor resource setups, it is difficult to get PEG also, and taking care of those persons who are living in the remote areas, coming for the follow-up visits. There are some logistic problems with the PEG also.
Yes. Yes, true. It is difficult to manage, but otherwise, PEG insertion is a routine procedure right now nowadays. Should not be a problem, but the availability of that gel infusion pump is still not there in our country right now. And as far as that MRI focused ultrasound is concerned, it is very expensive right now.
Okay.
So single procedure costs somewhere 25-30 lakhs, which is difficult.
Yes.
And it is recommended for unilateral one side only.
Dr. Amitabh sir, it was a nice presentation.
you.
And one thing I'd like to know that what is the cost of DBS at your center?
So we have two types of basically batteries. The procedure remains the same. We have two types of batteries. One is the chargeable one and the other one is non-rechargeable one. The non-rechargeable one, obviously, depending upon the amount of usage, the strength of the current, the frequency that one is using, would usually last for about 5 years. I've seen going up to 7 years. And the rechargeable one, obviously, is rechargeable. You have to charge it usually once a week or sometimes 10 days. And that is supposed to go for 20 years. The cost difference between the two batteries is about 5 to 6 lakhs. The total cost of the hardware
and hardware both.
hardware is around 13 to 14 lakhs. Negotiations, if you do, they can bring it down. But the first quote is like that. And obviously the insertion charges and all is like any other regular craniotomy. So if you have facilities for regular craniotomy and the whatever company you have chosen to come with, that will come. The Medtronic people have used only one scene ray, the rest have been not. So these people will bring their own frame. They will bring their own laptop, obviously for microelectrode recording. And the total package sometimes touches 20, but this is how it goes. Usual stay is 5 days, 4 to 5 days. And programming usually starts at 2 weeks. Usually.
So does it require an MRI suite?
No. Why MRI? All you don't even need an intra-op CT. So once you have put in the electrodes, you take the patient downstairs, which means to your CT room, do a CT scan, make a full covered dressing over the head, and take the patient for a CT scan, confirm that there is no bleed, and the leads are following that same trajectory that you had originally planned. So that CT, CD is brought to the OT again. It is fed into their computer, into the system, and it will correlate the actual lead that has been put in with the trajectory that you had originally planned. So if they are absolutely matching, then you start to close the wound. There is no need of intraoperative CT and definitely no.
Just like stereotactic surgery, frameless.
Actually, doing surgery is not a challenge. It is choosing the patient.
Yes,
and
that's most important.
Yeah, and the post-operative programming that is important. People will have the first, like you have 4 electrodes. Giving you the simplest example, not even going into the directional one. So if you have 4 exposed electrodes, then the first one or the second one or the third one or the fourth one, similarly on the other side. So you have to choose between one, and plus now with these new machines, you can have more than one electrode stimulating, which means you can have the first one and the second one, or you can have the first one and the third one, depending on what side effect or what positive effect the electrode is showing in for that particular current. And the current is also not to be the same for each electrode. You can choose 0.1 for one and the 0.5 for the other. So with directional, it is even more complicated, but then good for the patient.
Thank you, sir.
What is user battery life for it?
Like I said, battery life rechargeable. You have to charge every 7 to 10 days. For a fixed battery, which is to be changed at usually 5 years, sometimes 7. This battery can be switched off at night also. So you don't have to be stimulating the brain all 24/7. So with the help of the switching off process at night is done by the patient himself or herself. And as soon as the patient wants to get out of bed, the family member helps put the programmer next to the patient, and with just one click of button, it's like a smartphone device. It's got a touch thing also, and there are 2 types of a touch screen and a TV remote kind of thing. So you press that and it will start the process of stimulation again, the original program. Some amount of current variation can also be done by the patient's family also. So not all programming is done in the clinic hospital, but some leeway is given to the family also to try and stimulate. Obviously, thresholds are set, you cannot go beyond it. So there is no harm.
Right, sir.
So, any other questions from the audience? I think this was a nice and elaborative talk on medical as well as surgical management of Parkinson's disease. Dr. Vivek Kumar sir has elaborated the medical management and nuances of the this newer treatment modalities. So this was very nice and very informative talk. And Amitabh Goel sir has also described the everything about DBS. So it was a very informative talk for all of us. I extend my sincere thanks to both of our speakers for delivering such a nice talk. And I also thankful for both of my chairperson who has spared time for their busy schedule and helping me to coordinate this session, and also for the nice comments. I also extend my sincere thanks to all who have joined and all supports from my colleagues as well as the senior faculty members of the society. I would also like to thank a patient who is herself is doctor for nice feedback and questions from the our speaker experts and everyone. So thank you everyone for joining this session. Thank you. Good night.
Thank you, Dr.
Thank
Good
you,
night,
sir.
sir.
Good night. Good
Thank
night,
you,
sir.
sir.
Well, sir, good night.
Good night. Good night.
Thank you, sir. Thanks for joining with us.
Thank you.
So
Lovely session. Thank you.
thank you, sir. Thank you very much for joining. Madam, thank you
Very
very much
nice.
for coming for joining for staying with us.
Thank you.
Thank you, sir.